Okay. Ugh. This is gonna, there we go. Okay, so your veins act, and I think I kind of mentioned this last time as well. Your veins act as a big reservoir. They actually hold the bulk of the blood. We looked at that right here, right? We taught, and I remember talking about this last time. We're gonna have the bulk of our blood in our veins. So what happens when we start exercising? And when we start exercising, what's going to happen is our CO2 levels are going to rise. What happens when our CO2 levels rise? Our pH levels are going to change. And typically those pH levels are going to go down. We're going to become acidic to some extent, whatever extent that the blood can't buffer us. And then at that point, our respiration rate is going to increase. When we increase our respiration rate, we're also going to see an increase in blood. We're going to basically mobilize blood from the venous side of the system and put it into the arterial system. Why? Because we're hypoxic. So when we talked about the heart last time, or whenever we finished the heart, we talked about the return time, the venous return. We're going to return that blood into our right atria. So as we exercise or we're hypoxic, your body's going to kick out a response, which is going to return your venous blood. So we can takes blood out of that venous reservoir and put it into the atria and actually make it move through the arteries a little bit quicker. We call this capacitance, which I just think of capacity. We can stretch them so they hold more blood. We can constrict those veins also if we're losing blood. And this is important if we have sort of a hemorrhaging event and we're hemorrhaging blood out, we're going to see blood pressure drop and we're going to get hypoxic, right? Because we're losing blood, which is carrying oxygen. And so we're going to see venoconstriction. So our venous blood is going to constrict. What's it going to do? It's going to basically mobilize blood from our venous system into our arterial system, which again is going to increase oxygen delivery to the body parts. So this is just an important thing to know. Your veins act as a blood reservoir. We can move that blood from the veins into the artery side, and we see that happen especially when we have like hemorrhaging or something like that, and we get venoconstriction. Your total capillary blood flow equals your cardiac output. And then we look at resistance. Do you remember when we were talking about resistance last time? What was some things that cause pressure resistance to the heart in our vessels? Diameter of our vessels. So if we have a smaller vessel, there's more resistance than a larger vessel, right? What else? Length. So short vessels have less resistance than long vessels. What else? Turbulence. So we get this kind of stuff. We get our little rocks along the shore, right? And it's going to cause swirling, which is going to cause resistance. What else? Viscosity, thickness. So if it's thicker, it's going to flow a little slower. Yeah, it just means it's thicker. So if it's thicker, it's going to be harder to push it, right? So we might see thicker blood when we're dehydrated, right? Because if we're dehydrated, we've taken fluid, the plasma part of our blood out, it's going to flow. So those are really our big resistance factors. So if we're trying to get blood all the way to our capillaries, what we're going to be looking at is we're going to be looking at how much blood is the heart pushing out. And we looked at how can we affect how the blood pushes out, right? Our atrial return, our filling time, right? I'm sorry, my atria, I said atrial. But if I'm filling blood faster into here, I'm going to put more preload. Do you guys remember when we were talking about preload and afterload? So if I'm hypoxic, we just said we can speed up blood coming from the veins back into the atria, which gives us a bigger preload time. So we're going to dump more blood in here. If we've done things to make our heart constrict faster and harder, we can increase our cardiac output. So those are some things that we can do to change how blood affects our capillaries, is how much blood is coming out of our heart. That's our cardiac output. And then what is our resistance? If we need more blood to make it to our capillaries, the hope is that we can decrease the amount of resistance, right? How can we decrease resistance? Well, we can't really change the length of the vessels, right? Because if my foot needs oxygen, I can't shorten up the vessel going to my foot, right? I'm kind of toast when that goes. So what can I do? I can open up vessels. I can do some of these other things. Turbulence, we can't really do much about either, but really one of the big factors is going to be open up those blood vessels. All right. Pressure, I kind of talked about this. Do you guys remember the pressure gradients in the heart? What do I need higher pressure in here to do? When I increase pressure in my chambers, why am I increasing the pressure in my chambers? Yeah, to where the blood is going next, it has to, especially in the systemic side, I have to have enough pressure built up in this ventricle that it blows the valve open, right? So my pressure here has to be higher than it is here. This would be my systemic pressure. If the pressure builds higher here than here, it's going to push the valve open and blood's going to leave. But if I have resistance coming from here, that raises the systemic pressure out here, right? Which means my heart has to be even harder. So if we get resistance going out here, your heart has to work harder to overcome this kind of counter pressure to blow your valves open. All right, we talked about hydrostatic pressure versus osmotic pressure. Instead of reading all this, what is hydrostatic pressure? Yeah, pushes things out, right? It's like turning up the volume on our hose. That was our hydrostatic pressure. What was colloid osmotic pressure? The particle chemical gradient, right? If I have more particles here than I have here, stuff's going to move in. What creates the most amount of particles in our blood? That stays in the blood? Say it louder. Not sodium. It does create particles. It doesn't create the most amount of particles. It's my proteins. You remember when we talked about the albumins and all the metalloproteins, all those guys? So those proteins are too big to filter out of the blood vessels. So as I squeeze, do hydrostatic pressure, turn up the volume, things go out, but the proteins stay in. When I take the fluidy part out and the proteins stay in, that creates my particle gradient, right? So when I get to the venous side, things will come back in. Why? Because there's more particles in than there are out. So that hydrostatic with things that can't leave actually helps to create that osmotic, which is what pulls things back in. We never pull in as much as we push out, which is why we need a lymphatic system, right? Do you guys remember that about the lymphatic system? When I do push things out, I never pull as much back in. So I end up with extra fluid out here, my interstitial fluid, and it gets picked up by the lymphatic vessels, which we're going to jump into tonight. So the extra fluid gets picked up by those lymphatic vessels. What happens if it doesn't? Have you guys seen the pictures of people like with elephantitis? That is someone with a clogged lymphatic vessel. So what happens is we just keep pumping more fluid into our interstitial tissues and we pick back up on the venous side. And so you just begin to accumulate fluid in your body parts. So that's an example of what would happen. So our lymphatic vessels always mirror our circulatory vessels, and they pick this extra fluid up that goes out on the hydrostatic side, doesn't come back in on the colloid side. All right. When I talk about circulatory pressure, I mean, you don't have to read all this. They make it sound hard in here, but basically, we have to overcome our total peripheral resistance. What is it? It's this resistance right here. This is going to the periphery of my body. I have to overcome that resistance to blow my valves open on my heart. What are things that cause that pressure? These things right here that we talked about. So changes in what's going on in my peripheral vessels affect what my overall pressure ends up being. And I have to overcome it with my heart to push that blood out. And these are all the things you talked about. Vascular resistance is due to diameter of my vessels and the length of my vessels. So larger, shorter vessels have less resistance than longer, smaller vessels. All right, so I'm going to kind of cruise through some of this because we talked about it. Do you guys all feel comfortable with all of those? Okay. Cross-sectional areas. I think I did show you this last time. This is our luminal diameter. So the bigger vessels have big lumen. So we have a lot of blood and a lot of stuff flowing in our blood through the vessels, but this is where I was talking about. It's kind of like a super highway. If I had 50 cars crossing at once and I'm supposed to hand something to them, it's hard to do with 50 cars, right? Especially if one's way over on the other side. So I get a lot of flow through here, but do I have much exchange of stuff happening? No. So this is my exchange. We call it the area, the exchange area, basically. And you can see that as we get smaller, and remember when we were talking about they have to pass through single file? When those cells have to pass through single file, like red blood cells, now I'm going to have this high exchange rate. So superhighway has low exchange rate. Small windy country road has a much higher exchange rate. And this shows your blood pressure, much higher blood pressure the closer we are to the heart. Important to know your first vessels out of the heart are elastic arteries. Why are they important? They do that compress and recoil with the elastic tissues in there to protect these vessels from the high pressure coming out of the left side of the heart. So that's why these elastic arteries are really important. Is they're kind of protected arteries. They have that elastic tissue that allows them to compress and recoil. And then we're going to go to muscular arteries, arterioles. Arterioles, it's important to know, these guys have the most ability to change their size is at the arterial level. These are the vessels I can dilate or I can constrict is with the most amount of changes right here at the arterioles. All right, this shows velocity. This is how fast my blood's flowing through. It's really fast when it leaves the heart. Again, it's going to be really slow, comparatively speaking, as we get to the capillaries and the venules. Why? Because this is where we're doing our hydrostatic pressure and then our incoming osmotic pressure. All right, pulse pressure. Pulse pressure, this is important to know. I would write this down. Pulse pressure is the difference between my systolic and my diastolic pressure. So what's on the top? Do you guys remember systolic or diastolic? 120, what's the 120? Systolic over 80, which is diastolic. So what's my pulse pressure? 40. This is my pulse pressure right here. Mean arterial pressure, your MAP, is your diastolic pressure plus 1/3 of your pulse pressure. So I'm going to take this and divide it into thirds. I'm going to take my diastolic pressure and I add those together. That would be my mean arterial pressure, the average arterial pressure. And we said normal is 120 over 80. Hypertension's at 140 over 90. Hypotension means your blood pressure is really low, like abnormally low. Keep in mind that athletes are going to naturally have low blood pressures. They're going to have slower heart rates, higher cardiac output with each heart rate. Why? Their heart's a muscle and they've conditioned that muscle So their heart beats slower, but when it beats, it pushes higher volumes of blood out than the average Joe does. So sometimes you will see people that are fit or small, and they'll have lower, or it's also a genetic component to this. You may just run a little on the lower side of this. That doesn't mean it's always abnormally low. Some people, that is normal for them. Where would it be a problem if your blood pressure runs so low that it's causing disruptions of oxygen to your brain and things like that? Sometimes people pass out. Now we're in that hypotension area. Why do we need some amount of pressure? Well, we need that pressure to do our hydrostatic filtering at our capillaries. Elastic rebound, this is where we were kind of talking about those elastic arteries. They are going to compress or stretch, and then they'll come back. So when the heart pounds hard, they push away from the volume of blood. When the heart relaxes, that elastic tissue comes back, it recoils. I know in my class, we talk about that quite a bit with histology, so. All right. So your mean arterial pressure is going to decrease with the distance from the heart. So we're going to have less pressure in our vessels the farther we get away from the heart. That makes sense, right? And this shows kind of our mean arterial. You can see we're here in the big arteries. It's pretty high. It's moving with the rate of the heartbeat. We get down here and it really drops off. Venous return, again, our venous pressure is determining what comes back, which is going to be the preload to my heart. Again, if we have low blood pressure, we can faint, but we can also faint when we're not, like if you're laying down and you stand up all of a sudden, sometimes people get lightheaded or they'll faint. Why? How did we say we returned blood back to our heart using our veins? What were the two main ways we returned blood? Muscular contraction. So if I'm laying on the bed, am I contracting any muscles that are going to help? No. So all of a sudden I stand up and I didn't have enough muscles contracting, so I don't have enough return here, and it disrupts your oxygen supply, basically. Not that it shuts it off, but it's low enough it can cause passing out. So it's basically, that's why when you're laying down, you can get kind of lightheaded sometimes. Yes. Blood sugar, low blood sugar has to do with your ability to build ATP. I'm not exactly sure why it causes fainting, but I'm gonna guess it's tied to your ATP production. So I'd have to look at it though. So I have heard that before. Respiratory pumps the second way. As our diaphragm moves up, which is our relaxed position, or it contracts, which is our down position, we basically, it's like sucking with a straw. It sucks the blood up. So those are the two ways we pull venous blood back up: muscular contractions, and as our diaphragm moves up and down, it acts like a straw and it helps to pull that venous blood back up towards the heart. In between breaths and muscle contractions, remember our veins have valves. And so as we breathe and it moves past one valve, in the other half of the breath, the blood may try to fall, but the valves close and hold it there. And then with the next breath, it'll move up past the next valve. So it's a valved system that keeps it from falling back down. With our capillary exchange, we have diffusion, filtration, and reabsorption. What is diffusion? What's moving in diffusion? Water or particles? Particles. And what causes them to move? Is it passive or active transport? Passive. So it's moving down the concentration gradient. So if I have a capillary bed here, and they have the ability to pass the cell, or I'm sorry, the vessel wall. If I have more particles here and fewer here, things are going to move, right? They're going to go down the concentration gradient. That is diffusion. We're moving particles. If they're big and something has to help them across, but they're still flowing down the concentration gradient, there's still diffusion, right? We just call them facilitated diffusion. Something helped them move. But as long as they are flowing down their concentration gradient, we're going to call them diffusion. What is filtration? This involves your hydrostatic pressure. I'll give you a hint. So what does filtration mean? Yeah, we just turn volume up, right? And through pressure volume, anything, as we turn the pressure up, small particles or water or plasma, which really our plasma is mostly water, so I'm just going to put plasma here, is going to push out, and it's based on hydrostatic pressure. This is filtration. So this would involve my liquidy stuff, my plasma. When plasma leaves a vessel, it changes names. What do we call it as soon as it leaves a vessel? It becomes interstitial to fluid. So plasma becomes interstitial fluid, and then it gets picked up by a lymphatic vessel if it doesn't go back into the vein, right? What do we call it when the lymphatic vessel picks it up? Lymph. But this is all the same stuff. We just changed its name depending on where it's living. So if it's in a vessel, it's plasma. If it leaves a vessel, it becomes interstitial fluid. If it gets picked up by the lymphatic vessel, it becomes lymph. Lymph dumps it back into the blood. And then guess what? We changed its name back to plasma. So all of these are the same fluids. It just depends on where they're located. So with filtration, we will be filtering out plasma and anything small enough to go, but we're using the volume pressure. And then reabsorption, this is where we're taking things back into our vessel. What causes us to take things back into our vessel? Not hydrostatic, osmotic pressure, right? Where do I have more particles? If I have more particles here, if I have more particles of something out here, something small than I have here, these may move back in. But if I have more large particles, overall particles, my fluid might move back in. So we just move things down their concentration gradient back into the vessel. That's our reabsorption. All right, so we already said diffusion, we're moving things, particles down the concentration gradient. What are some of the things we diffuse? I would really not call water diffusion. What would we call the movement of water? Osmosis. So, but what are some things we move? Water, ions, small molecules. For diffusion, I would really say ions and small molecules. What are some of our ions? Sodium, potassium, calcium, chloride. Some of our large water soluble compounds will pass through vessels that have larger openings, or they may be facilitated across. Anything that's lipid soluble can go right through there. It has really no limitations to move right in and out. Why? Because we have our endothelium. What was our endothelium? It was the epithelial, right? The single layer of cells inside our vessels are their endothelium. And those membranes are phospholipids, which allow anything lipid to move across there because there's no charge to them. So we can move anything lipid soluble right through those, and oxygen really quickly and easily diffuses through there. That's important, right? We need oxygen to move easy. Plasma proteins can only cross the endothelium at sinusoids. Do you remember what a sinusoid is? When we talked about the spleen way back in 201, A sinusoid is basically a cavity, like a think of sinus cavity. There are cavities in different areas that are just like holding chambers of stuff. And you will have capillaries that come into these sinusoids, and they have bigger holes in those capillaries, which allow bigger things to come into the blood. This is how we get a lot of like our blood, our large proteins in. And those come a lot of times from our blood, or I'm sorry, our bone marrow. But we can also add, oh my gosh. We can also add our blood cells in through sinusoids, and it's capillaries in sinusoids that have bigger openings that allow those bigger things to come into circulation. Filtration, we said, is hydrostatic pressure. And then reabsorption is using osmotic pressure. This is where particles are driving what moves. Everybody good with, and you'll also hear called blood colloid osmotic pressure. So do you guys really understand the filtration process? We turn up the volume and we filter it out if it fits. And then we reabsorb it. What causes us to reabsorb it? The number of particles that are left. What's one of the biggest particles left? Large plasma proteins, because they can't go across. All right, so this kind of shows, here's our endothelial. Here you can see we have a few little gaps here. This is a blood vessel. Here we've turned up the volume. We have our hydrostatic pressure going. So these littler things that will fit through here basically just get forced out with volume pressure. All right. I'm going to kind of cruise through this because I talked about these. Capillary hydrostatic pressure is just basically how high do we turn up the volume in our capillary beds. And then we're going to have some amount of hydrostatic pressure outside of our capillaries, right? Because we have a volume outside of our capillaries. So as things want to filter out hydrostatically, we're going to have more pressure in our capillaries than we have in our interstitial fluid hydrostatically based on volume. If we don't, are things going to move out of the capillary beds? No, because we filter by having more volume here than we have here, correct? So if we lost our blood pressure was too low, and we had equal pressure on both sides of my vessels, would anything be filtering out of the capillary beds? No. So what's going to happen? We're going to have hypoxia. We're not going to get enough oxygen, nutrients, things like that. So your body has a way of kind of checking to see if our pressure in here is greater than our pressure here, so we can push things out. That's how we do our filters. So capillary hydrostatic pressure is just talking about what's the pressure here. Interstitial hydrostatic pressure is what's the pressure here. And the difference is what allows us to move things. If they're at equilibrium, nothing's going to move. Our colloid osmotic pressure is, again, the particle pressure. If we have a lower, say we're on the venous side and we don't have as many particles in here as we have here, are we going to pick things back up and reabsorb it? No, we're going to keep it in our interstitial fluids, which is going to create a problem because of waste and things like that. So there's this really nice balance between being able to push things out, filter it out, and then withdraw it back in. Fluid moves from capillaries to interstitial fluid. I kind of talked about that, right? It's plasma. It moves from here into my tissues. At that point, I'm going to call it interstitial fluid. We do not reabsorb as much from our interstitial fluids as what we push out in our capillaries using hydrostatic pressure. And that's where our lymphatic vessels have to come into play and pick the excess up. If they don't pick the excess up, we're going to see an accumulation of fluid in body parts. And this just shows you, I'm not going to ask you these numbers or anything, but here's an arterial. Coming down here becomes my capillary bed here. Here you can see my hydrostatic pressure, my filtration pressure. It's 35 inside the capillaries. What's pushing back against it is 25. So I'm going to basically filter out 10, right? because that's my difference of pressure. I have 10 more millimeters of mercury inside than outside, so I'll push some out. On my venous side, I'm reabsorbing, so now I'm looking at my particles over here, and when I look in here, I have 18 amount of, they're still looking at pressure here. This is filtration pressure, I'm sorry. And then this has 25, so things are going to move back in. All right, hemorrhaging is going to reduce our capillary hydrostatic pressure. Why? If I'm bleeding somewhere and I'm losing blood somewhere else, it makes sense that at other capillary areas, my pressure is going to go down, right? Because I'm losing blood out of this little vessel system. So if we're hemorrhaging, we are going to reduce our hydrostatic pressure. We're reducing our volume in our arterioles. We would see an increased reabsorption in the interstitial fluid. Dehydration increases my blood colloid. Why? Because when I'm dehydrated, I have less fluid in here and more particles, right? So we're going to see more particles in there. We're going to reabsorb fluid from my interstitial. So we're going to accelerate reabsorption into our blood. Why? Because we have more particles in our blood than we do out of our blood because we're dehydrated. So we have to have this nice balance between our hydrostatic pressure and our colloid pressure because it really determines how things are moving, either coming in or going out. Does that make sense? All right. Tissue perfusion, this just means what's going into our tissues, basically flowing through our tissues. We're going to carry oxygen and nutrients to our tissues and organs, and then it's going to carry CO2 and water, which is one of your cell respiration wastes, as well as other wastes away. What affects how much our oxygen is diffusing out into the tissues and the other things? Cardiac output, right? How much blood we're pushing out there. Peripheral resistance, because as we're resisting, we might change the amount coming out to the vessels, and then our blood pressure. So those are all the things that are going to affect what we have going into our tissues and coming out of our tissues. All right. Vasomotion, this is just contraction and relaxation of precapillary sphincters. Do you guys remember when I was talking, I kind of talked about it last time, and I talked about like with heat, we can close some capillary sphincters and route heat because our capillary beds are kind of like little intermediate roadways or roundabouts, so to speak. So if I had vessels, this was arterial side, venous side, I might have some routes that go this way and this way. And they have all these, some go through, some this way. And I can close these sphincters, which will determine which way the blood's going to go through these. If I have a tissue down here that's lacking O2, I can close some of these and make the blood come here. So now I can push O2 out into these tissues. So basically, vasomotion is just where your capillary beds are constantly changing these sphincters so that blood's routing. So we're providing tissues that need oxygen with oxygen. Cardiac output and blood pressure are autoregulated. They have neural mechanisms that can also affect them, and the endocrine system can also affect them. All right, I'm going to kind of cruise through these and talk about this. Autoregulation, this is basically looking at some of like these sphincter movements, things like that. With autoregulation right at that local level, it can make little changes to affect the route of our blood at our capillary beds. Like we were just talking, this would be an autoregulation. It would pick up that part of the tissue needed oxygen. It would make its own adjustments to allow that oxygen to go. So we can dilate, is another thing that we can do through auto regulation. If we're low in O2 somewhere, we can open up those vessels. If I open up the vessels, more blood flows through there, which allows more O2. These are some of the things that cause dilation: low O2 or high CO2. Lactate, what is lactate? Yeah, well, no, that's lactate. You're on the right track. Well, I mean, you're not wrong. That's what that is. Lactate is like lactic acid. So it comes, we see it show up when we don't have enough oxygen, right? That's what causes lactic acid, is a lack of O2. So if we become more acidic, we're going to put more oxygen into those areas. Nitric oxide, which is a waste byproduct, high potassium or hydrogen. Remember, hydrogen is going to make us more acidic. Inflammation, which is caused by our histamines, or elevated local temperature. Why? Because we're going to pick up that heat and we're going to get it moving. All right, we have a cardiovascular center. Here's what I want you to know about it. The medulla oblongata is in charge of your cardiac centers. The medulla can accelerate your heart. It can also inhibit your heart, which affects your cardiac output. That's important to know, that is that the medulla is in charge of that. That's our neural control of our cardiac output, comes from the medulla oblongata, and it can do both increase or inhibit. Which part of the nervous system would cause an increase? Yes. Sympathetic. Sympathetic's gonna speed my heart rate up, right? It's my adrenaline. Who's gonna calm it down? Parasympathetic. So medulla can kind of direct both of those. Speed that heart up, slow that heart down. All right, vasomotor tone. This just means we have some amount of tone, like we talked about with skeletal muscles. You have some amount of kind of background contraction that allows us to stand there. That's tone. We have the same kind of thing going on with the blood vessels and things like that. All right. You do need to know your baroreceptors and chemoreceptors. So what was a baroreceptor? It detected what? Stress or stretch or pressure, right? So where do I have big baroreceptors? This is important to know. Right here in my aorta. Why would I want a stretch or pressure receptor in my aorta? Yeah, if I pump blood too hard, what do I run the risk of? Blowing out my aorta. But it can also detect if my blood pressure is too low coming out of my aorta. What would be the circumstance of that? Maybe I'm not going to get blood all the way down to my foot or whatever. The other place we have baroreceptors is in our carotid arteries. Why would it be important to have baroreceptors at our carotid arteries? What happens if the blood pressure is too high in the main vessel going up into my brain? Yeah, I can basically explode those vessels. Okay, that might be a little exaggeration. It happens though, right? But I don't want too much pressure on the vessels going into my brain, because it could potentially cause a vessel blowout, which could cause a stroke, things like that. So you have receptors that are detecting the pressure going into your brain, going into the top of your heart. We also are going to see baroreceptors. This is not the only place we see them. We see them in the kidneys, at the filtration. We'll talk more about that with the urinary system. So there's other places, but those are some of the big ones to know: carotid artery, aorta. Chemoreceptors, these are testing my chemical composition. So again, I'm going to have chemoreceptors in some of these key areas. One of the big chemicals they're picking up on is my O2 CO2 levels. If CO2 gets too high, what's it do to my pH level? it lowers it. I'm going to see more hydrogen ion effects. So these chemoreceptors, these are big things they're picking up in CO2 and O2 levels. And this is how my body knows, hey, I'm lacking oxygen here. I am hypoxic. Why? Because chemoreceptors pick up the fact that we don't have enough oxygen. We're a little acidic in these areas. But again, carotid arteries, aorta, it makes sense, right? We want to protect our brain. We want to know what's going into the brain, making sure it has enough oxygen. Same thing going out into our system at our aorta. So those are big places we have that. Carotid arteries, aortic arteries. If our blood pressure is too high, your body is going to try to lower this blood pressure to protect itself. And what we're going to see is one, we're going to see the Bainbridge reflex. I talked about that. Where does that take place? Over here in our right atria. What was it? Do you guys remember what it was? Yeah, so they stretch too much on my return side. So I'm taking in too much blood here and the stretch receptors pick up and go, whoa, we're getting too much blood coming back. What caused my blood to come back? I was breathing faster and my muscles were moving. So how can I move that blood through there faster so I don't overstretch my atria? Speed that heart rate up. So I'm moving that blood out of there quicker. That is what your Bainbridge reflex is. It's basically picks up that right atria is stretching too much because we're returning so much blood, and it speeds that heart rate up so that we don't overstretch that. All right. Chemoreceptors, I said, we'll see them in the carotid arteries. Aortic, it's monitoring cerebral spinal fluid, which is basically what is our chemical composition to our brain. It controls respiratory function. Why? If I'm too acidic or too much CO2, what am I going to do? Speed up my respiration rate, right? Speed up my heart rate. The big chemicals, I already talked about this, pH levels, O2, CO2. What's the number one thing that drives pH down? CO2. All right. Endocrine, what are some of the endocrine things that you guys should hopefully feel kind of comfortable with this? But one of your big ones is going to be your adrenaline, right? Your norepinephrine, epinephrine. If I get an adrenaline rush hormone going through there, what's going to happen? Respiration rate's going to increase, heart rate's going to increase, cardiac output's going to increase. So those are some of the endocrine controls that we have. Again, epinephrine, norepinephrine. Antidiuretic hormone. So antidiuretic hormone gets secreted when blood pressure levels drop. Why do blood pressure levels drop? I'm losing water out of my plasma, and water is the largest component of plasma. So as I'm losing water and it's pumping out here, he's like, whoa, hey, our blood pressure's not high enough. What's one of the ways that I can quickly pick up my blood pressure? Put more water in it. So the kidneys are going to work in conjunction with my blood system, and they're going to hold on to aldosterone. Do you remember what aldosterone? Well, aldosterone is going to get secreted. What did aldosterone say to do? Hold on to salt. When I hold on to salt, I hold on to water. And antidiuretic hormone, remember, opens the little holes in the kidneys. So now I have a lot of this salt out here, and now water is going to go out to the salt. So between ADH hormone and aldosterone, we hold on to water at the kidneys, we dump it back into the bloodstream. Now we're going to put more water in our blood. We're going to increase the pressure by increasing the volume. All right. We have circulating angiotensin 2 is in there. Angiotensin 2, what does it do? It gets released from the kidney based on the kidney pressure, and it is what stimulates our aldosterone production. Aldosterone says, hold on to salt. We're going to see ADH secretion. It's going to make us thirsty. We're going to drink more water. And then we're going to vasoconstrict our peripheral vessels. Why? As I constrict these vessels, I'm going to create a higher pressure in those vessels. So I'll get filtration going still. Right? If I take a certain amount of volume, if I make my hose smaller, I can create more pressure with a smaller volume. If I make my hose bigger, it takes more fluid to create pressure, right? So if our blood pressure is low, we're going to see those vessels constrict to increase the blood pressure so we can still do filtration. Erythropoietin, EPO, kidneys secrete this, right? And we said it says, hey, make more red blood cells. Why would we do that? Chemoreceptors would detect we don't have enough oxygen going around here, so let's make more red blood cells, which can transport more oxygen. So this would be secreted due to low blood pressure as well, or low O2 content. Because red blood cells would increase my blood pressure as well, right? And they're going to be holding more oxygen. We're going to see more gas exchange, which is also going to increase volume in my blood. All right. AMP, atrial natriuretic peptide. This is produced in the cells in the right atrium. And there's also some that are tied to the brain. These respond to excessive diastolic pressure. What was diastolic pressure? Top or bottom number? Bottom number. So I have too high of a bottom number. It's going to reduce my blood volume. So that's what these hormones do, decrease blood volume. All right. Was everybody okay? Did I go too fast? Anybody need more time? Are you okay, Lauren?
Yeah.
Okay. All right, so blood, heart, cardiovascular system, and I would like to add the renal system in here a little bit, right? Renal system's really tied to the heart because we can affect blood pressure in there. But these guys really work together to regulate what's flowing through our vessels and flowing out to our tissues and the waste that's getting picked up at our tissue to maintain homeostasis. Like I said, I kind of threw the kidneys in here because they really help participate in this. We give a whole chapter to the kidneys though, so. All right. Vascular supply, basically the brain, the heart, and the lungs get priority of a lot of things because we really can't function in our other body parts if we don't have ample supply to the brain and the heart, and then the ability for the blood to go to the lungs and come back from the lungs. Brain is top priority. It does not. If we have low oxygen, we always give priority to the brain. Who gets rationed if blood oxygen levels are low? Skeletal muscle systems. So I don't need to sit there and flex my bicep if I don't have enough oxygen, but I need it to go to my brain. So your brain's always going to get this constant supply of oxygen, and we begin to ration it to body parts that aren't as important, like the skeletal muscle system. You should know what a CVA is. It's basically a cerebrovascular accident. It can be a stroke. A stroke is basically a disruption of delivery from a blood vessel. What can cause that disruption? A blockage or a blowout to the vessel. If we blow the vessel out, now the blood's leaking everywhere else and it's not going to the tissue that it needs to go to. So it can either block it or rupture it, but basically it's disrupting the flow to those tissues. Is everybody good? All right, blood flow to the heart. We talked about they come from the right and left coronary arteries. The heart has to get oxygen again. It gets priority, probably second to the brain and to the heart. If we have lactic acid or low O2 levels, we're going to dilate coronary vessels. We're going to open them up so blood flows through there and more oxygen goes into there, which is going to increase our output to our muscles. Epinephrine is going to open those up. Why? Because when we get an adrenaline rush, the heart has to beat faster. So now those muscles are working, they're going to need more oxygen. Blockage of coronary blood flow causes angina, tissue damage, heart failure, or death. Makes sense, right? Everybody good? All right, blood flow to the lungs. These are regulated by the O2 levels in the alveoli. So basically, it has chemo detection. It can tell how much oxygen is coming in there. As we have a high O2 content, vessels dilate. If we have a low O2 content, vessels constrict. Why? It's affecting my concentration gradient, my pressure gradient. Everybody good? All right, so if we're doing a light exercise, we're going to see vasodilation. Venous return is going to increase. Why is venous return increasing? Because my skeletal muscles are moving, right? And my respiration rate is increasing. That's the two ways I return blood on my venous side. So as I exercise, we see that speed up of my blood return. So our cardiac output is going to rise. Why? Because I'm going to stretch my atria and my blood's returning. So as venous return increases, heart rate's going to increase. Heavy exercise. This activates the sympathetic nervous system. Cardiac output's going to increase to the max. We're going to restrict the blood flow to non-essential organs like the digestive system. So it would be everything we'd see in a flight for life response. Reproductive system doesn't need that oxygen as much. Digestive system, urinary systems don't need it as much. We're going to redirect that blood flow to skeletal muscles, lungs, heart, and obviously the brain is going to get top priority. It says the blood supply to the brain is unaffected. Why? It never changes, no matter what we're doing, unless you have an illness or an incident going. We keep this constant oxygen supply to the brain. This is kind of a good picture to look at. If you look at the brain, here's our tissue blood flow. Look at the brain, never changes. The brain always gets the same amount of oxygen. Everybody else has to work around the brain. This kind of shows you skeletal muscles at rest, light exercise, strenuous exercise, heart. You can look at the rest of them, but I always think the brain's kind of interesting to see. It never changes. It gets constant supply. So with exercise, it moves your LDL cholesterols. Exercise actually lowers your LDL cholesterols. So every time you exercise, you are improving your heart health. Why? Because it moves these LDL proteins, your bad cholesterol, out of your system to some extent, which keeps it from developing plaques. And we know what plaques do, right? They create more resistance with that turbulence and reducing the size of vessels and all that other stuff. So it is true, even if you go out and walk, any kind of exercise you do is going to improve your vessel health. All right, your entire cardiovascular system is trying to maintain blood pressure, restore blood volume. All right, short-term elevation in blood pressure. If your carotid and aortic reflexes they detect that blood pressure changes have occurred, they can increase cardiac output. They can cause vasoconstriction. With sympathetic nervous system, we can further constrict it, which is going to cause more of that perfusion. And then hormonal effects are going to increase cardiac output. All right, shock. Shock is truly life-threatening when someone goes through some sort of big trauma and they go through shock, whether it's kind of psychological or it could be a physical shock from some sort of injury. But basically, we can lose up to 20% of our total blood volume from shock. What happens if that happens? If I decrease my volume, what do I decrease? I hydrostatic pressure, which is how I filter oxygen out to my tissues and my organs. If I can't get oxygen to my tissues and my organs, I'm going to begin to see systemic breakdown, systemic failure. So shock really can be a life-threatening event. So how can I offset that? I can recall fluids from the interstitial spaces, right? If my volume is low and my particles are higher in my blood, I'm going to pull that volume back in from my fluids. Aldosterone, ADH, we talked about those first, and EPO. All right. So peripheral artery and vein distribution is pretty much the same on both sides of the heart, near the heart. We've kind of looked at all these vessels in pretty good. I'm not going to spend a bunch of time on these because we went through them so well on the cadaver. I won't ask you about any vessels that weren't on the cadaver list. I do want to talk about our pulmonary pressures. So on our pulmonary circulation, we're taking blood in here and we're going to the lungs. That's my pulmonary circuit, right? And those are also going to be exchanging here in the lungs, and they're doing the same thing, a pressure gradient. So we'll look at that. I think I have a picture of that here for you guys. Systemic circuit. What's my systemic circuit? Pulmonary circuits, where it comes in through superior vena cava, goes to the lungs, comes back, right? Where's my systemic circuit start? Before that, you're on the right track though. It's going to be the whole left side of my heart and my ascending aorta, right? So it is the blood that now has oxygen that's going out to my system. And it's the systemic circuit until it comes back to the right atria again. So it starts at my left atria, ends at my superior and inferior vena cava. So 84% of our blood volume is in that route. Most of it's on the venous side, right? We said the vein holds the most amount of blood. Our systemic arteries go from left ventricle into ascending aorta. We're going to go to the coronary arteries, right? Where does it enter the coronary arteries? Right at the aorta, right? Right out of the valve. All right. And this takes us through all of these arteries, the vessels. I'm not going to ask you about any of those that aren't on your cadaver list. In fact, I don't even think I asked you about any of them on your, because we did them in lab. I don't think there was a single one on your lecture exam. A stroke is a CVA, and it's a disruption of blood, right? It can be blockage or a vessel blowout. You don't have to know about the circle of Willis. I think the whole rest of this is just talking about our individual blood supplies, which we already talked about. So I'm going to cruise through all of these. There's a lot of them, isn't there? All right, fetal and maternal cardiovascular systems. And we actually talked about this kind of in lab too. Blood doesn't have to go to a baby's lungs when they're in utero, right? We give our oxygen, goes from mom to the baby through the placenta, and then it bypasses. What are my two bypass locations in a fetus heart? Fossa ovalis and ductus arteriosus. Good. And that's between my pulmonary trunk and my aorta. The fossa ovalis is between my two atria. All right, so those are the big things you need to know here. That's a cute little baby. What causes basically my fossa ovalis to close when the baby takes their first breath? Kind of that negative pressure closes all those bypass systems. So the ductus arteriosus constricts as the O2 comes in from that deep breath, and then our fossa ovalis closes. What are the complications, or the foramen ovalis, and it becomes the fossa ovalis? One of those complications is sometimes you'll hear, oh, baby has a hole in their heart. Often this is what they're talking about, is this foramen ovalis that bypasses here sometimes doesn't completely close, and they'll go in and surgically close it. Yeah, they will go in and surgically close that hole. I think it's a pretty big deal. I don't know. Anybody know too much about it? I just know they can go in and close it, but you would get mixing of your deoxygenated, oxygenated blood if it doesn't close. That's going to affect my tissue perfusion, right? Babies will tend to have a bluish look to them. Why? They're not getting sufficient oxygen. All right. You don't have to know about this. We can have septum defects where our septum doesn't go all the way through, which will cause that. I don't quiz you on any of that, so that's why I'm going to cruise through it. Age-related changes to blood, heart, and blood vessels. So what happens when we get old? Well, one of the things that we see is we see a decline in hormones, which means we see a decline in tissue repair. We're going to see decreased hematocrit. Peripheral blockages. Why? Because we tend to have just more years on this earth, and we'll build up more plaquing in our arteries the longer we're on earth. And then we see more older people don't exercise as much. Why? Because their hormones have declined and their muscles break down, their bones break down, and they don't heal at the same rate. Their cartilages break down, they get arthritic. So it's discouraging to work out for them. And so now we're going to see increase in our cholesterol levels. They're all at risk of a higher risk of stroke and heart things. So really a big decline in hormones drives it. I always say the hormones are a fountain of youth. So as hormones decline, we're going to see kind of this stuff increase. Pooling in the blood, what do we call it? Where we get pooling in our veins because of our valves. The big visible veins. Do you remember? What'd you say? Oh, varicose veins. That's exactly what it is. So as we get old at our heart, we see reduced cardiac output. Our conducting cells may not work as well. Yes. Some do that. Some doctors you'll go to. That's kind of the big thing right now is the hormone replacement. They'll do the natural. Have you guys ever seen? I don't think it's on TV as much as it was, but there used to be a Synergenics commercial, and it had this guy who's like 80 years old, and he looked like Arnold Schwarzenegger. He's like all fit and muscular. And it was basically that's what it was. Is it was hormone replacement therapy. They were doing growth hormones, androgens, things like that. It is kind of the newer thing that they're doing now. A lot of doctors are doing hormone replacement, androgens for women as well as men, and so growth hormones, testosterones, things like that. Yeah, it's a muscle. Everything does. As your hormones decline, none of our tissues repair. Obviously, the heart muscles aren't going to repair anyway. But as we talked about, as hormones decline, our skeletal muscles don't repair. So at the same rate, so it hurts to go out for a run. So you don't go for a run or a walk or whatever. And that affects your heart health. It affects your cholesterol. So I would say hormones, even though they may not directly affect the heart, they affect enough of our other body tissues and systems that it does affect the heart. So again, hormones are kind of the new thing on the horizon is hormone replacement therapy. What they found is it's just hard when you're manually supplementing hormones. We don't have that real dynamic homeostasis. So one of the things I know, one of my friends was doing hormone replacement therapy, boom, like within a year, she had breast cancer. Well, they were giving her estrogens and testosterone. Well, estrogen can cause those cancers to grow. So if you have any kind of abnormal cells, it encourages growth. It's just it's in women, it acts kind of like a growth hormone to our secondary sex characteristics, which breasts are one of them. So anyway, if you have any abnormalities, it can cause those to kind of take off and go. So I think they're still kind of playing with hormone replacement. I'm not going to say it's bad by any means, but we don't have the ability to regulate it as precisely and perfectly as our body does. So you may see some bad effects from it. We see loss of elasticity to our heart, which is going to affect its ability to expand and contract. We kind of talked about all the rest of this. Atherosclerosis. Again, I think hormones are the biggest culprit. Arteries become less elastic, calcium deposits, lipid deposits, plaquing, all of those are due to lack of exercise, which goes to, I would say, lack of hormones. Disorders can affect a lot of other systems. The brain, we just kind of talked about exactly this. All those systems that get affected. All right, so that's our heart and our vessels. You guys okay? You want to take a little break, or you guys okay to truck on? Anybody care? All those different vessels? No. I'm not going to quiz you on any of the vessels. I will, what I do think is important is like where the chemoreceptors are, where the baroreceptors, but I'm not going to ask you all those little vessels in the brain. All right, let's jump into the lymphatic inlets. Does anybody want a break? No? Okay, let's check on, and maybe we'll quit a few minutes early then. We'll do our break at the end. How's that sound? All right, lymphatic system. Like I said, I'm going to kind of cruise through this because we have been a little behind. I'm just going to hit the highlights of the lymphatic system. You guys are going to get tortured in pathophysiology with a lot to do with the lymphatic system. So we are going to hit the high points and know that you'll probably get into a little more detail on it there. And if you take a microbio, anybody taking microbio or have taken it, you're going to study a lot of the immune system and microbio. So you're going to get it in a lot of other places. So I'm going to kind of brush the surface of it to give you guys an introduction to it. And then they'll actually go over it in a lot of detail. Lymphatic system, it really has two big functions to it. We've named one of them just with our circulatory system. What was it? We said lymphatic vessels mirror circulatory vessels. Why? Are you guys here? I have my vessel. It's pushing out plasma. What do we call plasma when it went here? Interstitial fluid. We push out more than we bring back in, right? So what do the lymphatic vessels do? They pick up that excessive fluid. So lymph vessels pick up that excessive fluid. And it comes from interstitial fluids. So that's one thing they do. And then there's one that we all know they do. What's the lymphatic system do besides this? Yeah, protection, immunity, right? So those are kind of our two big functions of our lymphatic system. It picks up excessive interstitial fluid that came out of the circulatory system, and it does the immune system. What kind of things is it going to give us immunity to? These right here: viruses, bacteria, fungi, parasites. And we're going to look at different ways the immune system functions. It kind of has, I'm going to say, three big ways it works. One is called is basically we're going to block it from coming into the body in the first place. How are some ways that we block things from coming into the body? In our skin, right? We put enzymes on the skin. The skin has our keratin in it, which isn't easy for things to travel through. All of our epithelial tissues sit on loose areolar connective tissue, and we learned back in 201 we had mast cells and macrophages, and we had those mast cells secreted heparin and histamines. So we began to have these blocking systems and these alert systems that if something does penetrate, we can sound the alarms. So we have that, but we also have a specific immunity. If we have something make it into the body, we can activate our cells to recognize it and then go build the antibodies to it. So if it comes back, we can attack it more quickly the second time. So we're going to kind of look at these different ways that the immune system attacks these things. Pathogens. This term pathogen is something that is foreign to the body. So when I'm talking pathogens, it's a foreign thing coming in. Do you remember when we talked about antigens with the blood system? What did we say an antigen was? A blood cell was an antigen. When we did this and we had A on here, what this was our antigen, what was it? It's on the blood cell. It is a protein, right? So antigens are proteins that are found on cells. Can I have antigens that belong to my body, that's their home? Yeah, we see that with the blood cells, right? So I can have antigens that are on my body cells that live there. But if I get a foreign cell in my body, it can also have an antigen. We talked about it with blood, right? If I put type B blood in here, and this is not a person that can accept type B blood, it sees this antigen that was at home in one body as a foreign antigen, right? So antigens can belong or they can be foreign antigens. Your body goes around and looks at these proteins. If it sees proteins that came from outside the body, we're probably going to call it a pathogen. We will also see that the body will read its own proteins and it has the ability to pick up a cell that has something gone wrong with it. Say it's getting a tumor, a cancer tumor, it's a malfunctioning cell. It has an antigen, but that antigen basically alerts the immune system, hey, I have something wrong with me. And the immune system will go and attack it and destroy it. So our immune system can scan for foreign proteins and it can scan for proteins that aren't working right in the body. So it can scan its own proteins for health and it can scan foreign proteins. All right, so lymphatic system protects us against diseases. It does environmental pathogens, toxins, abnormal body cells such as cancer. So it's just kind of scanning around the body, checking everything out, making sure it's healthy or it belongs there. Lymphocytes, these are part of the immune response. Lymphocytes are one of your immune cells, and they identify, attack, and develop immunity to specific antigens. So kind of look at how does it identify that it's either abnormal cell or it's a foreign cell that doesn't belong there. And then how does it sort of coordinate all the cells to go attack and destroy? So that's kind of the route we're headed in. All right, so immunity is basically the ability to resist infection and disease. And all body cells are involved in the production of immunity, not just the lymph system. All right, lymph, we talked about the fluid. It's similar to the plasma without the plasma proteins. Why wouldn't it have plasma proteins in it? Because they couldn't leave the plasma vessels, right? So the plasma proteins are still in my circulatory, but remember we said it changed names. It went from plasma to interstitial fluid. From interstitial fluid, it got picked up by a lymphatic vessel. Now we call it lymph. Where did my lymph eventually end up? Back in my circulatory system. So, but when it dumps it back, before it dumps it back into my circulatory system, it scans it at the lymph nodes with immune cells and it checks all the cells. So, for example, if I cut my arm and I had some bacteria got into the cut in my arm, I still have capillary beds in my arm, right? So I'm diffusing out stuff using hydrostatic pressure into interstitial fluid in my arm, but I cut my arm. So now I have some foreign cells that are floating around in my interstitial fluid. And along comes my lymph vessels, pick it up. Now they have a foreign bacterial cell along with my interstitial fluid. How bad would that be if I now dump that foreign bacteria back into my circulatory system? That's going to be pretty bad, right? Because now it can go anywhere. It can go to my heart, my lungs, my brain, anywhere. So we have our lymph nodes. And what these are their little checkpoints. And as this lymph is flowing back to, we basically dump in to the venous side of our circulatory system up in here. And before it gets there, it stops at all those lymph nodes. You know, the big areas, right? Like armpits, groins, but we have them everywhere. And we have these lymph nodes, and they have all these immune cells that are scanning everything as they go through there. If they find a foreign pathogen, cell that's abnormal, it will try to stop it there, and we'll see this big uptick of all these lymphocytes, which are now going to work to destroy these foreign cells. Why? So they don't get dumped back into our circulatory system. Are there times where stuff makes it through there? Yeah, absolutely. One of the big culprits is like staph infections. If you get a staph infection, it kind of sneaks through, sometimes sneaks through those lymphatic vessels, gets into your circulatory system, and now you have a big problem. But snake bites, they can get into the circulatory system, but a lot of them, they travel through the interstitial fluids, but they do affect. So getting something into the circulatory system, lymphatics is not the only way we can do it. If I damage a vessel, we can absorb it right up. It can also absorb in on the colloid side, depending on what it is. Some stuff will make it in on that side. All right, this shows all of our lymphatic vessels. So you can see we have several lymph nodes, big accumulation like armpit. Here's our thymus here, but you can see there's lots of them. We're going to start talking about the thoracic duct in a minute. The thoracic duct is right here. This is one of our dump-in points and our lymphatic duct. So these are kind of the 2 points where these dump into our venous systems. So when I talk about these, you'll know where I'm talking about. This shows your lymph vessels in the bottom. All right, lymphocytes are produced primarily in lymph tissues, red bone marrow, and thymus. Lymphocytes, we will talk about T cells and B cells, and I know I mentioned that. T cells are lymphocytes, are immune cells that come from the thymus. They are thymus dependent, they matured in the thymus. B cells mean it came from the bone marrow. So when you see these terms, B means it came from the bone marrow, T means it matured at the thymus. We also have some secondary lymph tissues, and these are going to be things like tonsils, your malt, which is found in your digestive system. Could I absorb a lot of foreign things through my digestive system? Yeah, because it's coming in from the outside world. So we have a pretty large accumulation of these in the digestive system. And that's what these guys are. Lymph nodes and spleen. Is everybody good? All right, so we already talked about what's its function. It's going to distribute lymphocytes. It's going to return that excessive fluid. We know all about that now, right? We're going to maintain normal blood volume. Why? Because if I wasn't picking up this excessive volume out of my interstitial tissues and dumping it back into my circulatory system, what would be happening to my blood volume in my circulatory system? I would be constantly losing more fluid than I was taking in, and we would constantly have low blood volume. So that return of that excessive fluid back to the circulatory system maintains our blood volume levels. We can also transport hormones, nutrients, and waste through the lymphatics. All right, what is the fluid found in lymphatic vessels? Lymph. What was lymph before it became lymph? Interstitial fluid. What was interstitial fluid before it became interstitial fluid? Plasma. You got it. All right, what do you need to know about the difference between lymphatic capillaries versus the capillaries on the circulatory system? They have a larger luminal diameter, have thinner walls, so things can come into them. But the big thing, this is what I really want you to know right here, is they have overlapped endothelial cells that act as a one-way cell. I'm sorry, one-way trapdoor, basically. So if I was looking at my endothelium, what's my endothelium? My inner lining. So I have these, I'm going to draw some big endothelium for you. They look kind of like this. And as fluid pushes up here, it will flap this open and stuff easily comes into the lymphs. And then the pressure coming down will push that shut. So it easily accumulates stuff. It does not lose stuff out of the lymphatic vessels because of this overlapping endothelial system. So things can easily come in. They can't come back out because the pressure causes that little trapdoor to shut. This allows fluid solutes, viruses, bacteria, everything to come in. They come in quite easily into the lymphatic system, which is why we need all those lymph nodes, because we don't want viruses and bacteria to come back into our circulatory system. So those lymph nodes are going to screen them, get rid of them. Okay, and your lymphatic vessels are going to mirror everywhere you have circulatory vessels, your lymphatics are going to mirror it. All right, and this, I'm going to cruise through some of this. This is important to know right here. Lacteals. We're going to especially talk about these in the digestive system, but on your mucosal lining, so your epithelial lining of your small intestines. Do you guys remember how they had villi on the small intestines like this, and then we have the microvilli? You have lacteals, so lymphatic vessels that run right in the middle of the lacteals. These guys are important because they actually absorb lipids at my small intestine. So they're kind of unique in that they pick up lipids in the digestive system. So that is another function of our lymphatic system, very unique to the small intestines. All right, everybody good? Everybody good? Like I said, I'm skipping a lot of stuff. I'm trying to stop and pause on the things that are important. This just shows some of your, all right, these two things are important that you need to know right here is your two major collecting areas. Our two places we're gonna dump our lymphatic fluid back into our circulatory system is at our thoracic duct and our right lymphatic duct. And they are by no means equal. It's not like I do half of it comes in from my right side of the body and half of it comes in from the left side of the body. It's more like 3/4 of it comes in from one side and 1/4 comes in from the other side. But these are the two, and I'm going to show you a picture here in a second, but these are the two big ones to know. Your thoracic duct collects the most amount of lymph. All right, so you don't have to know any of these. Here's what I want you to know. So the thoracic duct collects lymph fluid from all of this side of the body. Your right lymphatic duct only kind of does your right side of your head and your right arm. Everything else comes in from the thoracic duct. Which I find interesting. I don't know why it's so uneven, but it is. Everybody good? All right, so that was important. This shows a picture right here. Here we have our jugular vein. We're familiar with this, right? And here's our subclavian. This is where your thoracic dumps into your venous system is right there, kind of at that branch of your subclavian. When we looked at the cadaver, remember how we had a whole bunch of tissue kind of right at that branch? Hiding in there is your lymphatics on that side. This shows the other side. It's kind of the same thing. Here's our jugular here. Here's our subclavian. This is our thoracic duct coming in there, kind of right at that branch. So that's where we dump all that fluid back in. Important to know the thoracic duct maintains or takes back the largest amount. What is lymphedema? If we get a blockage of a lymph vessel, it's elephantitis. That's what happens. When a person gets elephantitis, I always pick on elephantitis because I think the pictures are super interesting. But basically, if I clog a lymphatic vessel, I can't pick up the excessive fluid there. So I'm just going to keep accumulating fluid there. That's not the only, elephantitis is not basically what it is blockage. It usually comes from parasites or things. We see it in third world countries, but you'll see people walking around that just have some sort of, sometimes autoimmune diseases, things like that, that have affected their lymphatic vessels. And maybe they'll have an arm or a leg that swells. Does that mean you have to walk around with one arm that's 3 times the size of the other because of the interstitial fluid? No. How do they fix it? They usually do compression wraps, and that compression wrap will push the fluid in the tissues in the interstitial fluid up until it hits a working lymphatic vessel, and then that vessel will pick it up. So we can treat this as kind of an external treatment. Lymphocytes make 20 to 40% of my circulating leukocytes. Most are stored, not circulating. Everybody good? All right, we talked about lymphocytes, T cells. They're thymus dependent. What does that mean? They got matured at the thymus. B cells come from our bone marrow. And then we have our natural killer cells. Natural killer cells target, this is how I remember what they do. Natural killer cells target cells that are natural to the body. So NK cells are targeting our own body cells, our own cells. So what's it looking for? It's looking for cells that have some sort of abnormality going to them. And when they have some sort of an abnormality going to them, they will usually display an antigen on their surface that basically says, hey, something's wrong with me, and natural killer cells will take care of that. Germinal center, this is important. Germinal center is just an area where we're basically dividing lymphocytes. What do I want you to know about? Where do I find these? In lymph nodes, the spleen, respiratory tract, which is really in our tonsil portion of our respiratory tract. And then we find them in the digestive, urinary, and reproductive tracts. Why? These guys have indirect contact with the outside world. And so they're going to be more exposed to foreign things. So know what a germinal center is and know it's located in these areas. Everybody good? All right, this shows the intestines here. This is just showing a germinal center in here. It's just where we have dividing lymphocytes. Again, why would it be important in the intestines? Because we're absorbing things from the outside world. Let's show some more. All right, in our pharynx, we have sets of tonsils. It's important to know your tonsils are located in your pharynx, and they are basically picking up anything foreign. Why would we want it in our pharynx? One, it's shared piping between our respiratory system. Are we going to pick up pathogens, toxins, fungi, things like that in our respiratory system? Possibly. And it's also shared tubing with our digestive system. Are we going to pick up foreign stuff in our, yeah, absolutely, right? Digestive system's really bad for it. So our pharyngeal tonsils are called our adenoids. Our palatine tonsils, these are the ones we mostly think of as our tonsils, is our palatine tonsils. Those are the ones back on the sides, back here that you can see that, like, usually if someone gets strep throat, it's in their palatine tonsils. And then we have some lingual tonsils. So what's tonsillitis? Remember, itis means inflammation of. It's going to be inflammation of the tonsils. Again, palatine tonsils are the biggest culprits. They get affected the most. Usually when they go in and do a tonsillectomy, they take out the palatine tonsils. Sometimes they'll take out the adenoids. I don't think they try to do the adenoids as much as they used to. Everybody good? All right, and this kind of shows pharyngeal tonsils are up here kind of back at the nasal area. Palatines, those are the ones again here. Lingual are kind of a little deeper under the tongue area. All right. The MALT, it's the mucosa-associated lymphoid tissues. Your lining to your digestive system is called the mucosa. Why? It secretes mucus, but it's your epithelial lining. So we have these mucosa-associated lymphatic tissue. Why is it important we have lymphatic tissue in our digestive tract, especially our small intestines? We're absorbing stuff, which might include some little foreign thing that has made its way through. So these are just basically lymphoid centers in our digestive system. The appendix, they think, contains a mass of lymphoid nodules, which is not only does it have some fecal particles in your appendix, but you also have lymphoid tissue, which has trapped foreign things. When you get appendicitis and your appendix bursts, that's why it's so deadly. Basically, you die of the infection in your abdominal area from foreign things and fecal matter that just now goes all over your stomach. You don't have to know about these aggregated lymph nodules. Just know this is going to be associated with your digestive system. Is everybody good? All right, lymph organs include lymph nodes, thymus, spleen. That's important to know. Everybody good with that? You don't have to know any of these. I'm not going to ask you the anatomy, the incoming, outgoing, going vessels of the lymph nodes. So you don't have to worry about any of those. You can skip all that. We are purifying our lymph at the lymph nodes, though, right? You should know the function. Lymph nodes are cleansing that fluid before we dump it back into the circulatory system. So 99% of antigens get removed at the lymph nodes before they get dumped back into the circulatory system. We're going to see macrophages and lymphocytes found in those lymph nodes, and dendritic cells, which are a form of your immune cells. All right. You don't have to know that. All right, thymus. Thymus is found right, it's above our heart, below our thyroid. It's found right here. It is very large when you are a baby. By the time you're an adult, like our cadavers, we can't even find the thymus. It shrinks and shrivels and basically goes away. They say there might be some amount of tissue, but it's really not visible anymore. Why does it go away? Because we've matured these T cells and they're out there and they're in circulation and they're doing what they need to do. So now we don't need our thymus. So they're big in children. Why? Because children are developing their immune system. Once you have a fully established immune system, we don't need that thymus as much. So we will see our thymus kind of shrink and go away. You don't have to know any of the structures of it. What's the hormone for the thymus? Thymosin. What does it do? It just promotes maturation. You have those T cells. So what would happen if a child didn't secrete enough thymosin? they're going to have immune issues. They're going to be prone to illness, which could be quite devastating depending on what it is. Why? Because they don't have an established immune system. So that's all you need to know here. Here shows a picture of a thymus. Here's our thyroid. So it's kind of between your thyroid and your heart here. We're not going to ask you any of that. Okay, spleen. Spleen, I've mentioned in 201, if you had me, it's the graveyard for dead red blood cells. So it takes damaged red blood cells out of circulation, but it also helps with initiating immune response of both B cells and T cells. So your spleen helps with kind of the maturation of these cells. So it is involved with both B cells and T cells, which is unique. Can we live without our spleen? Yes. One of the side effects of living without your spleen is you'd be a little more prone to getting sick. Why? Because the spleen does this right here. All right. You don't have to know the anatomy of the spleen. All right. Immunity is the ability to resist and defend infections. Resistance is the ability to maintain immunity. Immune response is if we detect some sort of a foreign antigen, now we're going to launch an attack against it. And it's any abnormal substance. This can be from outside the body, or it can be something that's abnormal within my own body. All right, this is important to know. What is innate or non-specific immunity? It always works the same way, and it can't differentiate responses. Basically, it's going to respond the same way every single time it detects a foreign antigen. So it is what we'll see like under our skin and places like that. It can't say, oh, this is staph. I'm going to go do a staph attack, or this is bacteria from rust. I'm going to go do an attack for this. It doesn't know the difference. It just treats everything the same. So it's quick and it works well, but targeted ones work better. So what is adaptive or specific immunity? These are the ones that know exactly what it's fighting against. It says, oh, this is staph, or oh, this is that, and it will launch a very specific attack. How do we get specific immunity? We have to be exposed to it. Our body battles it, beats it, and then it remembers how to beat it. So that now going forward, we can always beat it. The second it comes into the body, our body recognizes it, remembers it, attacks it, beats it, and we won't even realize that it came into our body because our body will take care of it so quickly. But how did we get there? We had to be exposed to it. This is where vaccines come in. Like when they vaccinate, they'll usually inject you with a weakened or a dead form of whatever it's putting into your body. And they make it weak enough or dead so that your body will go beat it, but now your body will remember it. All right, lymphocytes, B cells, T cells, NK cells. Where do B cells come from? T cells. Thymus, what do NK cells do? Our own cells, our natural killer cells. All right. Lymphocytes wander through tissues. They're going in and out of lymphatic vessels, into the bloodstream, into interstitial tissues, back into lymphatics. So they're just kind of wandering around. Lymphocytopoiesis. I don't ask you anything about that, but this is just going to be making lymphocytes. And again, they come from bone marrow, thymus, some of our peripheral lymphoid tissues, like those germinal centers. Lymphoid, so in our bone marrow cells, we're producing B cells and natural killer cells. So make sure you add in this, our natural killer cells come from our bone marrow. How do we differentiate into B cells? It's when we're exposed to interleukin. Interleukin, you'll also hear them called like IL messages. And basically they're little chemical cries for help. And when they get secreted by some sort of a tissue that recognizes something foreign, and it's basically their way of alerting the rest of the body. So if we get some sort of a little chemical cry for help, B cells will go differentiate. The second group of lymphoid stem cells migrate to the thymus, and these differentiate with exposure to hormones. Which hormone? Thymosin. The big thing I want you to know is B cells, NK cells come from bone marrow, T cells come from the thymus. I'm not going to ask you about the differentiation, other than I want you to know that exposure to chemicals causes that differentiation, and we've talked about that. All right, so these are some of our cells that we're going to be looking at are NK cells. They can attack body cells, foreign cells that are within the body cells, cancer cells, and they basically are going to secrete things that lyse a cell. So basically they'll put a chemical into the cell, cause that cell to sort of self-destruct. B cells, these are the ones that make your antibodies. So that's important to know. And then cytotoxic T cells, these are the cells that, again, will secrete something into an abnormal cell, break it up, destroy it. All right. T cells and B cells, these migrate throughout the body. What are our non-specific defenses? Again, these can't differentiate. They treat everything the same. I'll probably kind of do innate defenses and then quit for tonight. We'll finish up the next time, the rest next time. So what are our innate defenses? Physical barriers. What's our physical barriers? It's things like skin, mucous membranes, and like tears in our eyes, some of those enzymes that are at openings of our bodies. Those are going to be physical barriers that hope to trap and keep things from coming into the body in the first place. Phagocytes. What do phagocytes do? They do phagocytosis, right? They engulf and destroy, and they don't care what it is. They see a foreign cell, they're going to try to engulf and destroy it. Immune surveillance, these are going to be cells that kind of march around and are checking things. We'll talk about those in more detail. Interferons, these are my chemicals that I can pass on. The complement system, inflammation, and fever. And we're going to kind of go through each of these. So, but those are all things. What did innate immunity mean? Yep, any kind of thing. It's non-specific. All right, so here's some of our physical barriers. I mentioned a few, but these are going to be things like enzymes and wax and oils and mucus secretions and the skin itself. Mucus secretions like at the mouth, this pick the skin, but any opening to your body has some physical barriers to it. Eyes have your tears with enzymes. Phagocytes, we have fixed macrophages. We found this in loose areolar connective tissue. If you remember, we have free macrophages, monocytes, eosinophils, neutrophils. Neutrophils, if you remember back to 201, and we also talked about it here, are the most abundant white blood cell found in the bloodstream. Natural killer cells, these are seeking out abnormal cells in our body, and they're going to seek and basically destroy abnormal cells. Interferons, these are chemical messages. Most of them are targeting viral infections. So basically they secrete a signal which warns surrounding cells, hey, we have a virus. I'm getting attacked by a virus here. And those surrounding cells will kind of put up their defenses so they're not as easily attacked by those viruses. These are the signals that help with chemical exposure for differentiation and things like that. complement system. This is just where we have these circulating proteins, and they help with basically our antibodies. And what they can do is they can attach to these foreign surfaces and help with lysing or breaking down foreign cells with foreign antigens. Inflammation, these come from mast cells. We talked about these quite a bit with loose areolar connective tissue. These are inflammatory. They do the histamines and the heparins, so they increase blood flow, they activate macrophages, increase permeability. So what is that? More blood flow to there. With the blood flow, I can bring more lymphocytes and macrophages and all those cells that are going to help with fighting things. They can do clotting, increase temperature. Why? It's hard for bacteria and viruses to reproduce when we turn the heat up on them because they need proteins, right? And what happens when we turn the heat up on proteins? Denatures them. So that is why we get a fever, is we're trying to kill off and denature foreign proteins without doing it to ourselves. And then we can activate our adaptive defenses. These would be our specific immune system. And then fever, which kind of goes along with this, increases our temperature, increases our tissue metabolism. Raising that temperature prevents the spread of those foreign proteins / cells. All right, so physical barriers, I kind of talked about all these guys. Everybody get with what the physical barriers are? Phagocytes, what do? Phagocytosis. Just to know a few of their names. Macrophages are the big ones to know. How do we activate macrophages? Basically, they're going to recognize a foreign antigen and say, hey, this is a pathogen, right? A pathogen was a cell that's a foreign antigen. And then they're going to engulf it like the little Pac-Man cells and break it down. How do they break it down? They basically put toxic chemicals into it, which lyse those foreign cells. We have fixed macrophages. These basically are stuck in their area of the tissue. Free ones can float around. Chemotaxis. Chemotaxis is just basically a chemical that gets secreted that cells, think of it like the food truck is cooking down there and we all smell it and we're like, go to the food truck. Chemotaxis is like that for immune cells. It releases a chemical and all those immune cells follow that chemical signal to the site that it needs to go to. So just know that term. Immune surveillance, this is our natural killer cells. They're looking for these abnormal cells in the body. They have, this is important, perforins. You should know that. They release perforins, which basically, remember Golgi apparatus make vesicles that secrete chemicals out of the cell membrane using exocytosis. You guys remember that? All right, so what they do is they secrete those perforins in. The perforins then basically are an enzyme and they break down and destroy these cells. So they go in through the cell's plasma membrane and they basically destroy it using those enzyme chemicals. I'm going to stop here because this gets into recognition a little bit more. Well, actually, I could do it because we're not going to do all that. But basically, here's a natural killer cell recognized an abnormal cell. Here it has the perforins. The perforins go into the abnormal cell, break it down. All right, I will stop here. So we're on slide 80, and I'll pick this up on Tuesday with you guys. Just a quick reminder, on Thursday, you guys have your exam, so I'll turn you loose. I know there's quite a few people who take their exam in their computer lab. So you guys will have the ability to go do that. Did you have a question? For a lab? Yeah. For a lab, bring your respiratory handout. I can write that up here. Respiratory handout. And bring your lab practical number 3 guidelines. There's no post labs, but bring these handouts with you. We're going to be doing a breathing lab, a respiratory breathing lab. On Thursday, they're gonna let us breathe, which is great. So we'll do that. And if we have time, we'll start into some of the other stuff but we may not have time, which is fine because the last practical is super easy, in my opinion. Usually people do